Hi, my name is Stephanie, and today I thought we could go over some of the further guidance published at the University of Washington regarding the diagnosis of autism spectrum disorder according to the DSM-V. So this is further guidance for psychologists who are looking to diagnose people under the DSM-V. This, I believe, was before it was completely finalized, but it was published and released in 2013 to help psychologists. So let me make it clear that this is a guide to assist professionals in diagnosis. Specifically the criteria of the DSM-V we've gone over before in a video. I'll link that for you to see. But I think that going over what might be better examples and maybe help people to better translate what they're looking at might help people understand if going to get a diagnosis is really worth their time. Please note that I'm not diagnosing you or anything like that. Obviously, only a professional can do that. Just want to make all those sorts of things clear, and that this is a publication from the University of Washington, not directly from the DSM-V. Now that I got that out of the way, one more thing, actually two. First thing, shout out Autism isn't a dirty word, merch and other design merch, also non-hoodies, whatever, all the things. You can check that out in my merch shop. It's linked below. And the other thing is this book here. This is a book by Sarah, the Autistic OT. If you are not familiar with her, you should definitely look her up. If you didn't know, I am trying to get into my occupational therapy assistant program at my school, and so it's been really cool to kind of see an autistic OT or occupational therapist and really kind of become friends with her and listen to her and all her things. So this is actually aimed at children. It's for helping to regulate maybe big emotions or feeling overwhelmed, and kind of learning how to, acknowledge those things and then be able to let them go. But a lot of adults have also found it helpful. So I'm gonna go ahead and leave the link to this book and where you can get it. All right guys, I'm moving myself over here. Hopefully you will see the document on the other side so we can just kind of do this together. I apologize that this isn't the most fanciest thing in the whole wide world, but I thought it might be helpful. So general guidelines. One example of a specific criterion may not be sufficient to assign the criterion as present. So here are some questions you might want to ask yourself, or the professional might ask themselves. Is the example behavior clearly atypical? This is clearly not normal. Is the example behavior present across multiple contexts? This happens more than once, right? This happens in many situations. It didn't happen just one time. Distinguish between behaviors that are clearly atypical and present across multiple contexts versus behaviors that are on the borderline of being atypical or rarely occur or occur in only one context. For example, while toe walking may be an example of criterion B1, it may not be sufficient by itself to assign the criterion if there is a physical explanation for the behavior and thus not clearly atypical, and or if it occurs only in one context, such as at the beach when barefoot in sand. So, if something's hurting their heel and that's why they're toe walking, or if obviously there was a reason to be walking on your toes and that's the only time that happens, then obviously that criterion is not generally present. By contrast, a preoccupation with lawnmowers that involves obsessively drawing lawnmowers, seeking out lawnmowers, and talking about lawnmowers is sufficient to meet criterion B3, even if no other examples exist. This preoccupation is clearly atypical and is present across multiple contexts. Avoid using the same exact behavioral exemplar to satisfy two criteria. Some behaviors may appear to satisfy multiple DSM-V criteria. It is the responsibility of the clinician to decide where the behavior is best represented. For example, repetitively putting hands over ears may satisfy B1 because it is a repetitive motor movement, or it may be considered under B4 because it represents an adverse reaction to sounds. So, for example, if this often happens in reaction to sounds and they also do rocking, then we should probably put rocking in the repetitive motor movement and leave the hand pressing to the ear kind of thing to the adverse reaction to sound, instead of trying to use the hand pressing over the ears for both. So particular behaviors or actions should not be just duplicated. So you don't want to just apply, oh, you know, they put their hands over their ears for like 3 different things, if that makes sense. Some behaviors are multifaceted and may satisfy multiple DSM-V criteria. For example, a child who is obsessed with strings and insists on always carrying string with him at all times may meet criteria for B3 due to a strong attachment to an unusual object. If the same child also frequently waves string in front of his face and watches it flop up and down, then B4 should also be considered due to the visual sensory aspect of this behavior. Behaviors that are not currently present may be considered. A behavior that only occurred in the past may be sufficient to assign a criterion. It is important to consider whether a behavior that occurred in the past is atypical for developmental norms. For example, hand flapping should not be counted if it only occurred from 6 to 9 months of age. So that's interesting to me. I was not aware that it might be typical for 6 to 9 month old children to be hand flapping. But, you know, if it persists in 1 year and 2 years and maybe is not as noticeable in 5 years, it might still be something to count. Everything is subject to change. This is my favorite part. And by favorite, I mean not favorite, because that's the whole thing with really diagnoses and medicine and psychiatry, psychology, all of these things, is that people are doing their absolute best, but when it comes to this stuff, especially when it comes to things we can't objectively test, I guess, where we have to go based off of like a bunch of criteria and behaviors and things we can see and observe, rather than be like, oh yes, you have or don't have this by a blood test or something. You know, it can be difficult and it's frustrating. The final publication of the DSM-V of May 2013 may provide more guidance on the number of behavioral exemplars required. The number of required criteria may change and major changes are possible. So again, while we go over this for maybe a better guidance, if you are wondering what exactly constitutes as autism, does what I have actually fit the criteria, remember that this is supposed to kind of help, but at the end of the day, the official criteria set forth in the DSM-V is the official standard when it comes to diagnosis. So if there's anything in here that is or isn't in the DSM-V video I went over with you guys, the actual criteria rather, just be aware of all the things for technical purposes. So DSM-V criteria for ASD with examples. A, persistent deficits in social communication and social interaction across contexts, not accounted for by general developmental delays and manifests by 3 of 3 symptoms. A1, deficits in social emotional reciprocity, ranging from abnormal social approach and failure of normal back and forth conversation through reduced sharing of interests, emotions, and affect, and response to total lack of initiation of social interaction. So here we see what we recently discussed about affect. This here is more of the reciprocated. This isn't necessarily just in general, but when someone is interacting. If you have no idea what I'm talking about when I say affect, please go ahead and check out the video I did on that one. Abnormal social approach might include unusual social initiations like intrusive touching or licking of others, or use of others as tools. I've had some pretty interesting initiations of contact with others, and there's also kind of like a lack of understanding of space and what might be appropriate. That's just a personal thing that I've seen. Failure of a normal back and forth conversation, poor pragmatic or social use of language, does not clarify if not understood, it does not provide background information. Yeah. Failure to respond when name called or when directly spoken to, does not initiate conversation, one-sided conversations, monologues, or tangential speech. So this could also be kind of like when people info dump. You get us started on something and then we kind of took over the conversation. I find myself doing this a lot. Reduced sharing of interest, so doesn't really like to share, lack of showing, bringing, or pointing out objects of interest to other people, or impairments in joint attention, so that's both initiating and responding. reduced sharing of emotions or affect, lack of responsive social smile. So note the focus here is on the response to another person's smile. Other aspects of emotional expression should be considered under A2. So this is if like I smiled at you, but would you immediately kind of smile back and reciprocate that with your face? We kind of talked about this a lot in the flat affect video. Some people think that they're smiling and they might not be. This might also kind of play effect in that, so there's that too. Failure to share enjoyment, excitement, or achievement with others. Failure to respond to praise. Does not show pleasure in social interactions. Failure to offer comfort to others. Indifference or aversion to physical contact and affection. That is interesting. Indifference or aversion to physical contact and affection. Putting that under reduced sharing of emotions and affect, that's kind of interesting to me. That's obviously like a big thing you think of, or I think of when I think of autism, and yet I don't know, I just wouldn't categorize it there, but that's interesting. Lack of initiation of social interaction, only initiates to get help, or limited social initiations, kind of like we're only going to start this conversation, or I'm only gonna talk to you or get your attention because I need help. There has to be like an actual purpose to this interaction before I'm actually gonna go out of my way. It's not just to casually be like, oh hey, like, oh look, I'm playing with my toy, like that kind of stuff. Now note, this is also very based on outward signs. Someone not showing enjoyment in a conversation doesn't mean they don't enjoy the conversation. Someone not offering comfort, that might be because they don't know how to, or they don't know what to do in the situation, or maybe in that moment they don't understand why you would need comfort. Moving on to A2, deficits in nonverbal communicative behaviors used for social interaction, ranging from poorly integrated verbal and nonverbal communication through abnormalities in eye contact and body language, or deficits in understanding and use of nonverbal communication to total lack of facial expression or gestures. So we see impairments in social use of eye contact. This is something we've gone over before, why eye contact might be difficult for some people. Impairment in the use and understanding of body postures, like facing away from a listener, kind of like not understanding how the position of your body might matter to other people, or like how to properly show that you're apart with your body and other nonverbal ways, basically. Impairment in the use and understanding of gestures, so that's pointing or waving, nodding or shaking your head. Some people might not understand or might not use them. Abnormal volume, abnormal volume, pitch, intonation, rate, rhythm, stress, prosody, or volume in speech. I'm just getting silly now, sorry. Abnormalities in use and understanding of affect. Note, responsive social smile should be considered under A1, while affect that is inappropriate for the context should be considered under A3. So just noting like what we mean in affect in these situations. Impairment in the use of facial expressions may be limited or exaggerated. Lack of warm, joyful expressions directed at others. Limited communication of own affect, inability to convey a range of emotion via words, expressions, tone of voice, or gestures. Inability to recognize or interpret others' nonverbal expressions. Lack of coordinated verbal and nonverbal communication, so the inability to coordinate eye contact or body language with words is an example. Lack of coordinated nonverbal communication, inability to coordinate eye contact with gestures. I don't know if we're saying like over there and not like looking over there, or if we're talking about like when we're gesturing and we're looking at someone. I'm not 100% on that. You can tell me what you think that means. A3, deficits in developing and maintaining relationships appropriate to developmental level, beyond those with caregivers, ranging from difficulties adjusting behavior to suit different social contexts through difficulties in sharing imaginative play and in making friends to an apparent absence of interest in people. Deficits in developing and maintaining relationships appropriate to developmental level. Lack theory of mind, inability to take another person's perspective. CA is greater than or equal to 4 years. This would be something at certain ages, because the idea is that children go in developmental stages and develop parts of theory of mind at a certain age. This is a whole thing. This is on like perspective taking and understanding other people's point of view while understanding your own. It's kind of a complex process, very difficult for children and adults alike, in my personal opinion. There's a whole lot of things that people feel about theory of mind, but I do also have a video on that if you're interested. I'm probably going to be linking a lot of things. Difficulties adjusting behavior to suit social contexts. Does not notice another person's lack of interest in an activity. Lack of response to contextual cues. Example, social cues from others indicating a change in behavior is implicitly requested. So like people kind of getting irritated or something, like when they move their bodies kind of uncomfortably. I say that as though normal people writhe and move like I do. Something my mom taught me, because I tend to have problems modulating or I don't know, my voice level, is she would always do this. So when people are getting like out of hand, I do this to people to tell them to shh. Anyway, so I guess that's more of an obvious, it's not really necessarily a contextual cue. Inappropriate expressions of emotion, laughing or smiling out of context. Note, other abnormalities in the use and understanding of emotion should be considered under A2. Unaware of social conventions or appropriate social behavior, asks socially inappropriate questions, or makes socially inappropriate statements. This sometimes might be considered having no filter. That's a personal note. Does not notice another's distress or disinterest. Does not recognize when not welcome in a play or conversational setting. This is why it's like so easy for people to get bullied, I'm just saying. Limited recognition of social emotions. Does not notice when he or she is being teased. Does not notice how his or her behavior impacts others emotionally. And a lot of times, sometimes it's like I can't tell, like I know something's off, but like I don't know how exactly I'm being teased. I've experienced things like that. Difficulties in sharing imaginative play. Note, solitary imaginative play or role-playing is not captured here. Lack of imaginative play with peers, including social role-playing. This would be older than 4 years of developmental age. Difficulties in making friends, so does not try to establish friendships, does not have preferred friends. Lack of cooperative play, over 24 months of developmental age. Parallel play only, like you play with your things right here and I'll play with my things here, but like don't mess up what I'm doing. Unaware of being teased or ridiculed by other children, does not play in groups of children, does not play with children his or her age or developmental level, only older or younger. Has an interest in friendship but lacks understanding of the conventions of social interactions, example, extremely directive or rigid or overly passive. Does not respond to the social approaches of other children. Absence of interest in others. Lack of interest in peers. Withdrawn, aloof, in own world. Does not try to attract the attention of others. Limited interest in others. Unaware or oblivious to children or adults. Limited interaction with others. And prefers solitary activities. Again, please note that some people do really just not have much interest in other people at all, and some people just may appear to not be. They might just kind of be off in their own world. It doesn't necessarily mean they like don't care about other people, if that makes sense. B. Restricted repetitive patterns of behavior, interests, or activities as manifested by at least 2 of 4 symptoms. B1. Stereotyped or repetitive speech, motor movements, or use of objects, such as simple motor stereotypies, echolalia, repetitive use of objects, or idiosyncratic phrases. So we have gone over echolalia when they're talking about stereotypies. That is also termed stimming. Stereotyped or repetitive speech, pedantic speech or unusually formal language. Child speaks like an adult or a little professor. Echolalia, immediate or delayed, may include repetition of words, phrases, or more extensive songs or dialogue. Jargon or gibberish, mature jargoning after developmental age of 24 months. Use of rote language. Idiosyncratic or metaphorical language. language that has meaning only to those familiar with the individual's communication style, neologisms, pronoun reversal, for example, you for I, not just mixing up gender pronouns, so instead of saying I want a sandwich, they would say you want a sandwich, refers to self by own name, does not use I, so instead of saying I want that, they would say Stephanie wants that. Perseverative language, note for perseveration on a specific topic, consider B3. Repetitive vocalizations, such as repetitive guttural sounds, intonational noise making, unusual squealing, or repetitive humming. Stereotyped or repetitive motor movements, repetitive hand movements, for example, clapping, finger flipping, flapping. Well, I do more like this than I do like this. I guess some do this, but I do more like that. Okay, no one cares. Okay. Twisting. I twist a lot. I used to twist my arm like up weird and stuff. Anyway. Stereotyped or complex whole body movements, foot to foot rocking, dipping and swaying, spinning. Y'all, they're calling me out. They're calling me out hard right now. Abnormalities of posture, for example, toe walking or full body posturing. Intense body tensing, unusual facial grimacing, excessive teeth grinding, repetitively puts hands over ears. Note if this is a response to sound, consider B4. Perseverative or repetitive action, play, or behavior. Note if two or more components, then it is a routine and should be considered under B2. Repetitive picking, unless clear tactile sensory component, then consider B4. Stereotyped or repetitive use of objects. Non-functional play with objects like waving sticks or dropping items. Lines up toys or objects, repetitively opens and closes doors, and repetitively turns lights on and off. I know a little boy who does that. B2, excessive adherence to routines, ritualized patterns of verbal or nonverbal behavior, or excessive resistance to change, such as motoric rituals, insistence on the same route or food, repetitive questioning, or extreme distress at small changes. Adherence to routine. Routines, specific, unusual, multi-step sequences of behavior. Insistence on rigidly following specific routines. Note, exclude bedtime routines unless components or level of adherence is atypical and unusual routines. Ritualized patterns of verbal and nonverbal behavior. Repetitive questioning about a particular topic, distinguished from saying the same word or phrase over and over, which goes under B1. Verbal rituals, has to say one or more things in a specific way or requires others to say things or answer questions in a specific way. I believe sometimes this is called scripting, and some people will have to like run through a script and they will begin again if you respond wrong or if you like mess up their script. I think this might be what they're kind of saying. Compulsions, example, insistence on turning in a circle 3 times before entering a room. Note the repetitive use of objects, including lining up toys, should be considered under B1. Excessive resistance to change, difficulty with transitions should be out of the range of what is typical for children of that developmental level, and overreaction to trivial changes, moving items at the dinner table or driving an alternate route. Rigid thinking, inability to understand humor, inability to understand non-literal aspects of speech, such as irony or implied meaning, or excessively rigid, inflexible, or rule-bound in behavior or thought. B3, highly restricted, fixated interests that are abnormal in intensity or focus, such as strong attachment to or preoccupation with unusual objects, excessively circumscribed, or perseverative interests. Note, consider B1 for perseverative speech. Preoccupations, obsessions, interests that are abnormal in intensity, narrow range of interests, focused on the same few objects, topics, or activities, preoccupation with numbers, letters, or symbols, being overly perfectionistic, interests that are abnormal in focus, excessive focus on non-relevant or non-functional parts of objects, preoccupations, example, color, timetables, historical events, etc., attachment to unusual inanimate object, example, piece of string or rubber band, having to carry around or hold specific or unusual objects, not common attachment objects such as blankets, stuffed animals, etc., Unusual fears, example, afraid of people wearing earrings. B4, hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment, such as apparent indifference to pain, heat, or cold, adverse response to specific sounds or textures, excessive smelling or touching of objects, fascination with lights or spinning objects. A high tolerance for pain, that is not something I have. Poking own eyes, preoccupation with texture or touch, includes attraction or aversion to texture. Tactile defensiveness, does not like to be touched by certain objects or textures. Significant aversion to having hair or toenails cut or teeth brushed. Unusual visual exploration or activity. Close visual inspection of objects or self for no clear purpose. For example, holding things at unusual angles, no vision impairment. I just realized I do that. I have a visual impairment, but it's not like I'm nearsighted, but I'll still bring things like, but like there's no point to do that, I guess, technically. So I did it. Sorry, I just realized I did something. It just cracked me up. Unusual squinting of eyes, extreme interest or fascination with watching the movement of other things. For example, the spinning wheels of toys, the opening and closing of doors, electric fan, or other rapidly revolving object. All domains of sensory stimuli, sound, smell, taste, vestibular, visual, consider odd responses to sensory input, becoming extremely distressed by the atypical sound, atypical and or persistent focus on sensory input. Unusual sensory exploration with objects, sound, smell, taste, or vestibular. For example, licking or sniffing objects, note as part of a ritual, consider B2. Licking or sniffing people, consider A1. C. Symptoms must be present in early childhood, but may not become fully manifest until social demands exceed limited capacities. Early primary caregiver report is no longer essential. Early childhood, approximately age 8 and younger, and this is flexible. D. Symptoms together limit and impair everyday functioning. Select one severity level specifier for social communication and one for restricted interests and repetitive behaviors. Minimal social impairments. Without supports in place, deficits in social communication cause noticeable impairments, has difficulty initiating social interactions, and demonstrates clear examples of atypical or unsuccessful responses to social overtures of others. May appear to have decreased interest in social interactions. That's from the DSM-V severity rating. Minimal RRB impairments. Rituals and repetitive behaviors, RRBs, cause significant interference with functioning in one or more contexts. Resists attempts by others to interrupt RRBs or to be redirected from fixated interest. And then they kind of go into the levels. I've gone over the levels before over on Indie Andy's channel. I'll also link that. Behaviors and symptoms that are not or may not be captured in the DSM-5 ASD include problems with play and imagination, impairments in imaginative or symbolic play, lack of functional play skills, and difficulty distinguishing fantasy from reality. That is very interesting because I had heard that before and I thought that was strange because I just did not identify with that. So that's interesting that that is not necessarily specified in the DSM-5. Shyness and social anxiety are not actually captured in the actual criteria, apparently. Language and developmental delays, milestone delays or developmental delays, speech delays, expressive or receptive, and language disorder, behavioral difficulties or temper tantrums, poor imitation skills, poor social imitation skills are captured. Now, this was done by a PhD and BCBA, their associate professor of pediatrics. As much as I'm not exactly a fan of ABA and BCBAs and everything, they do work with autistic children, and it looks like a collaborative effort, and they're pretty good at seeing behaviors, which is kind of right now how we get diagnoses, is observation. Anyway, I'll go ahead and link that in the description for you to check out if you want to. I highly recommend just remembering that the DSM-5 itself again, is the official criteria, blah, 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 all that stuff. Thank you so much for watching. I hope that it helped maybe give you some more examples of what might fulfill certain criteria for the ASD diagnosis in the DSM-5. And if you enjoyed it, go ahead and give it a like. Let me know your thoughts in the comments below. And I upload autism-related things to this channel every Thursday at 4 p.m. Central Standard Time, so feel free to subscribe if that interests you.
Thank you to my patrons for supporting me over on Patreon. And a special thank you to my Spaz tier patrons, Brian Kleinhammer and Jesse Graves.
Thank you so much for watching. I hope you're having a wonderful week, and see me in my next video. Bye!